Welcome to Pediatric Case Review. Today's lecture covers Seckel Syndrome, a rare genetic disorder characterized by intrauterine growth retardation and distinctive craniofacial features. We will explore clinical presentation, diagnostic approaches, management strategies, and genetic counseling. This comprehensive review will enhance your clinical knowledge for better patient care. Let's begin with our first case. A newborn presents with severe microcephaly, low birth weight at 36 weeks gestation, and a receding forehead. The parents are healthy and consanguineous. What is the inheritance pattern of Seckel syndrome? Option A, autosomal dominant. Option B, autosomal recessive. Option C, X-linked recessive. Option D, mitochondrial inheritance. The correct answer is B, autosomal recessive. Seckel syndrome follows autosomal recessive inheritance, meaning both parents are typically healthy carriers. Each pregnancy has a 25% chance of being affected. Multiple genes have been identified, including ATR, RBBP8, CMPJ, CEP152, CEP63, and NIN, and DNA2. These genes are crucial for DNA damage response and centrosome function during cell division. Case 2. A 38-week neonate weighs 1,800 grams with head circumference of 27 centimeters. Length is 41 centimeters. What best describes this presentation? Option A, asymmetric growth restriction. Option B, proportionate primordial dwarfism. Option C, constitutional growth delay. Option D, macrocephaly with short stature. The correct answer is B. Seckel syndrome presents with proportionate primordial dwarfism, meaning growth restriction begins at conception. All growth parameters including weight, length, and head circumference are proportionately reduced. Birth weight is typically below the 3rd percentile. Unlike asymmetric growth restriction where head is relatively spared, Seckel syndrome shows severe microcephaly from birth, making it distinctive. Case 3. A 2-year-old child with Seckel syndrome is examined. Which facial feature is most characteristic? Option A, flat facial profile with frontal bossing. Option B, bird-like face with prominent nose. Option C, round face with full cheeks. Option D, elongated face with prognathism. The correct answer is B. Seckel syndrome is historically called bird-headed dwarfism due to the distinctive facial appearance. Patients have a prominent beaked nose, receding forehead, and micrognathia creating a bird-like profile. The eyes appear large relative to the small face. Ears are typically low-set and malformed. This unique combination makes the diagnosis clinically recognizable. Case 4. Parents of a 5-year-old with Seckel syndrome ask about developmental expectations. Brain imaging shows simplified gyral pattern. What is the most likely cognitive outcome? Option A, normal intelligence. Option B, borderline intelligence with learning disabilities. Option C, moderate to severe intellectual disability. Option D, progressive cognitive decline. The correct answer is C. Most individuals with Seckel syndrome have moderate to severe intellectual disability, though severity varies. Brain imaging often reveals structural abnormalities, including simplified gyral pattern, corpus callosum hypoplasia, and reduced brain volume. The intellectual disability is non-progressive, meaning it does not worsen over time. Early intervention and educational support are essential for maximizing developmental potential. Case 5. Radiographs of a 3-year-old with Seckel syndrome show delayed bone age, clinodactyly of 5th fingers, and hip dysplasia. Which additional skeletal finding is common? Option A, 11 pairs of ribs. Option B, vertebral segmentation defects. Option C, radial ray defects. Option D, craniosynostosis. The correct answer is A. Approximately 40% of Seckel syndrome patients have 11 pairs of ribs instead of the normal 12. Hip dysplasia or dislocation occurs frequently, requiring orthopedic monitoring. Clinodactyly and syndactyly affect the hands. Bone age is consistently delayed throughout childhood. Scoliosis may develop and require surveillance. These skeletal findings contribute to the overall short stature. Case 6. A 7-year-old with Seckel syndrome develops pancytopenia. Bone marrow examination shows hypocellularity. What hematological complication should be considered? Option A, hemolytic anemia. Option B, aplastic anemia. Option C, acute leukemia. Option D, immune thrombocytopenia. The correct answer is B. Seckel syndrome patients have increased risk of aplastic anemia due to underlying DNA repair defects affecting bone marrow function. Pancytopenia develops with hypocellular bone marrow. Additionally, acute myeloid leukemia has been reported. Regular complete blood count monitoring is essential. Any persistent cytopenias warrant hematology referral for bone marrow evaluation and appropriate management. Case 7. During examination of an infant with Seckel syndrome, The ophthalmologist notes absent red reflex bilaterally. What ocular finding is most likely? Option A, retinoblastoma. Option B, congenital cataracts. Option C, persistent hyperplastic primary vitreous. Option D, congenital glaucoma. The correct answer is B. Congenital cataracts occur in up to 30% of Seckel syndrome patients, causing absent red reflex and visual impairment. Strabismus is very common and requires early intervention. Chorioretinal dysplasia and significant refractive errors also occur. Annual comprehensive ophthalmological examination is recommended from infancy to detect and manage these conditions, optimizing visual development and quality of life. Case 8. A 4-year-old with Seckel syndrome has delayed tooth eruption. Examination reveals crowded dentition and high-arched palate. What dental complication requires monitoring? Option A, amelogenesis imperfecta. Option B, multiple dental caries. Option C, premature tooth loss. Option D, gingival hyperplasia. The correct answer is B. Dental caries are common due to crowded dentition making hygiene difficult, combined with small jaw size and potential feeding difficulties. Tooth eruption is typically delayed. The high-arched palate and micrognathia contribute to malocclusion. Regular pediatric dental visits, preventive fluoride treatment, and eventual orthodontic intervention are important. Teaching caregivers proper oral hygiene techniques is essential. Case 9. Echocardiography in a newborn with Seckel syndrome reveals a structural heart defect. Which cardiac anomaly is most frequently associated? Option A, tetralogy of Fallot. Option B, atrial septal defect. Option C, patent ductus arteriosus. Option D, aortic stenosis. The correct answer is C. Congenital heart defects occur in 20 to 30% of Seckel syndrome patients. Patent ductus arteriosus and ventricular septal defects are most commonly reported. Echocardiography screening should be performed at diagnosis. Cardiology referral is indicated for confirmed defects. The presence of cardiac anomalies influences perioperative planning and requires consideration during any surgical procedures throughout life. Case 10. Ultrasound in a male neonate with Seckel syndrome shows unilateral renal agenesis. Physical examination reveals cryptorchidism. Which statement about genitourinary involvement is correct? Option A, renal anomalies are rare. Option B, males always have normal external genitalia. Option C, renal and genital abnormalities occur variably. Option D, females never have reproductive tract anomalies. The correct answer is C. Genitourinary abnormalities occur variably in Seckel syndrome. Renal anomalies include unilateral agenesis, dysplasia, or hydronephrosis. Males may have cryptorchidism or hypospadias. Females can have uterine or ovarian abnormalities. Renal ultrasound should be performed at diagnosis to identify structural anomalies. Cryptorchidism requires urological referral. Regular monitoring of renal function is appropriate. Case 11. Parents inquire about growth hormone therapy for their 6-year-old with Seckel syndrome who remains below the first percentile for height. What is the expected response? Option A, significant height gained to normal range. Option B, minimal to no response. Option C, normal growth velocity achieved. Option D, growth hormone deficiency always present. The correct answer is B. Growth hormone therapy shows minimal to no response in Seckel syndrome. This is primordial dwarfism, not growth hormone deficiency. Growth hormone levels are typically normal, but cellular resistance to growth signals exists. IGF-1 pathway dysfunction may contribute. Currently, no effective treatment increases height. Management focuses on addressing complications, developmental support, and optimizing quality of life. Case 12. A 3-year-old with Seckel syndrome requires inguinal hernia repair. Anesthesia review notes micrognathia and cervical spine instability. What is the primary anesthetic concern? Option A, malignant hyperthermia risk. Option B, difficult airway management. Option C, cardiac arrhythmias. Option D, prolonged drug metabolism. The correct answer is B. Difficult airway management is the primary concern due to micrognathia, receding chin, and small facial structures making intubation challenging. Cervical spine instability may coexist, requiring careful positioning. The patient's small size necessitates specialized pediatric equipment. Underlying congenital heart defects affect anesthetic planning. An experienced pediatric anesthesiologist should manage these cases with appropriate preparedness for difficult intubation. Case 13. A geneticist explains that the ATR gene mutation in a patient with Seckel syndrome disrupts cellular processes. Which fundamental process is impaired? Option A, glycolysis and energy production. Option B, DNA damage response and repair. Option C, protein synthesis and folding. Option D, lipid metabolism. The correct answer is B. The ATR gene and other genes implicated in Seckel syndrome are crucial for DNA damage response and repair. ATR protein detects DNA replication stress and activates cell cycle checkpoints. Mutations cause checkpoint dysfunction, impaired centrosome formation, and defective DNA repair. This particularly affects rapidly dividing cells during fetal development, resulting in microcephaly and severe growth restriction from conception. Case 14. Research on CNPJ gene mutations in Seckel syndrome reveals abnormal centrosome numbers in patient fibroblasts. How does centrosome dysfunction contribute to microcephaly? Option A. Neurons undergo apoptosis from mitotic errors. Option B. Axonal transport is disrupted. Option C. Myelin formation is impaired. Option D. Neurotransmitter synthesis fails. The correct answer is A. Centrosomes are essential for organizing the mitotic spindle during cell division. CNPJ, CEP152, and CEP63 genes regulate centrosome duplication. Mutations cause abnormal centrosome numbers, leading to mitotic errors in rapidly dividing mural progenitor cells. These errors trigger apoptosis, dramatically reducing neurogenesis during brain development. The result is severe microcephaly with reduced neuron numbers and simplified brain architecture. Case 15. A newborn with severe microcephaly, intrauterine growth restriction, and bird-like facies is suspected to have Seckel syndrome. What is the most definitive diagnostic test? Option A. Karyotype analysis. Option B. Skeletal survey radiographs. Option C. Molecular genetic testing. Option D. Brain magnetic resonance imaging. The correct answer is C. Molecular genetic testing through gene panel or whole exome sequencing is the most definitive diagnostic approach. This identifies pathogenic mutations in known Seckel syndrome genes including ATR, RBBP8, CNPJ, CEP152, CEP63, NN, and DNA2. Genetic confirmation enables accurate diagnosis, prognostication, and genetic counseling for recurrence risk. Testing may be negative if a novel gene is responsible. Case 16. Brain magnetic resonance imaging is ordered for a child with Seckel syndrome. Which finding is most characteristic? Option A. Dandy-Walker malformation. Option B. Lissencephaly. Option C. Simplified gyral pattern with small brain volume. Option D. Periventricular leukomalacia. The correct answer is C. Brain magnetic resonance imaging characteristically shows proportionately small brain volume with simplified gyral pattern, meaning fewer and broader gyri than normal. The corpus callosum may be hypoplastic or dysgenetic. Mild ventriculomegaly can occur secondary to reduced brain tissue. Cerebellar hypoplasia is occasionally seen. These findings reflect impaired neurogenesis during fetal development consistent with the underlying cellular dysfunction. Case 17. A couple with one affected child requests prenatal testing in their current pregnancy. Second trimester ultrasound shows severe symmetrical growth restriction and microcephaly. What prenatal diagnostic option confirms Seckel syndrome? Option A. Maternal serum alpha-fetoprotein. Option B. Amniocentesis with molecular testing. Option C. Chorionic villus sampling karyotype. Option D. Doppler umbilical artery studies. The correct answer is B. Amniocentesis with molecular genetic testing can confirm Seckel syndrome prenatally if the familial mutation is known. Either amniocentesis or chorionic villus sampling obtains fetal DNA for targeted mutation analysis. Prenatal ultrasound findings suggestive of Seckel syndrome include severe symmetrical growth restriction and microcephaly evident from early gestation. Prenatal diagnosis enables couples to make informed decisions and prepare for specialized neonatal care. Case 18. A newborn with microcephaly, growth restriction, and facial dysmorphism needs diagnostic evaluation. Which condition must be differentiated from Seckel syndrome? Option A. Down syndrome. Option B. Fetal alcohol syndrome. Option C. Microcephalic osteodysplastic primordial dwarfism type 2. Option D. Achondroplasia. The correct answer is C. Microcephalic osteodysplastic primordial dwarfism type 2 must be differentiated from Seckel syndrome as both present with severe microcephaly and primordial dwarfism. MOPD type 2 typically shows more prominent skeletal dysplasia and has higher risk for moyamoya disease and cerebrovascular complications. It results from PCNT gene mutations affecting centrosome function. Molecular genetic testing definitively distinguishes these conditions, guiding surveillance protocols. Case 19. A pediatrician coordinates care for a child with Seckel syndrome. Which specialist should be included in the multidisciplinary team? Option A. only genetics and pediatrics. Option B, multiple specialists including genetics, neurology, orthopedics, ophthalmology. Option C, only developmental pediatrics. Option D, genetics and endocrinology only. The correct answer is B, comprehensive management requires a multidisciplinary team. Clinical genetics provides diagnosis confirmation and counseling. Neurology and developmental pediatrics address intellectual disability and seizures. Orthopedics manages hip dysplasia, scoliosis, and limb abnormalities. Annual ophthalmology screening is essential. Cardiology follows congenital heart defects. Pediatric dentistry, hematology, and other specialists are involved as complications arise. Coordinated care optimizes outcomes. Case 20. Parents of a 5-year-old with Seckel Syndrome and moderate intellectual disability ask about school placement. What educational approach is most appropriate? Option A, regular classroom without support. Option B, homeschooling exclusively. Option C, individualized education program with special education services. Option D, residential institution placement. The correct answer is C, an individualized education program tailored to the child's cognitive and physical abilities is most appropriate. This includes special education services, speech therapy for communication delays, occupational therapy for fine motor skills, and physical therapy for gross motor development. Social skills training supports peer interaction. Inclusion in regular classrooms for appropriate activities promotes socialization while ensuring necessary academic support and modifications. Case 21. An infant with Seckel syndrome has poor weight gain despite adequate feeding attempts. Evaluation shows micronathia and gastroesophageal reflux. What intervention may be necessary? Option A, intravenous nutrition permanently. Option B, modified feeding position and thickened feeds or gastrostomy tube. Option C, no intervention needed. Option D, total parenteral nutrition exclusively. The correct answer is B, feeding difficulties are common due to micronathia and gastroesophageal reflux. Initial management includes upright feeding position, small frequent meals, and thickened feeds. Anti-reflux medications may help. If oral feeding remains inadequate despite interventions, gastrostomy tube placement ensures adequate nutrition for growth and development. A pediatric nutritionist should guide caloric requirements and feeding strategies. Regular growth monitoring is essential. Case 22. A 4-year-old with Seckel syndrome develops generalized tonic-clonic seizures. Electroencephalogram shows epileptiform activity. What is the appropriate management approach? Option A, observation without treatment. Option B, antiepileptic medication and neurology follow-up. Option C, surgical intervention immediately. Option D, dietary modification only. The correct answer is B, seizures occur in some Seckel syndrome patients due to structural brain abnormalities. Standard antiepileptic medications are effective. A pediatric neurologist should select appropriate medication based on seizure type, electroencephalogram findings, and patient-specific factors. Regular monitoring for therapeutic levels, side effects, and seizure control is necessary. Medication dosing requires adjustment for the child's small body size. Most seizures are controllable with appropriate treatment. Case 23. Parents ask whether their child with Seckel syndrome can receive routine vaccinations. The child has moderate intellectual disability, but no other active medical problems currently. What is the recommendation? Option A, all vaccines contraindicated. Option B, follow standard immunization schedule. Option C, live vaccines only contraindicated. Option D, delay all vaccines until adulthood. The correct answer is B. There is no contraindication to routine immunizations in Seckel syndrome. Children should follow the standard pediatric vaccine schedule. Immunization is especially important as these children may have increased vulnerability to infections and complications from preventable diseases. Annual influenza vaccination is recommended. Pneumococcal vaccines per schedule should be administered. Vaccination protects against serious infectious diseases and complications. Case 24. Radiographs of a 6-year-old with Seckel syndrome show progressive hip dysplasia with subluxation. What management is indicated? Option A, no intervention, self-resolves. Option B, physical therapy only. Option C, orthopedic surgery consultation. Option D, casting without surgery. The correct answer is C. Hip dysplasia is common in Seckel syndrome and may progress to subluxation or dislocation. Orthopedic surgery consultation is necessary to evaluate severity and determine appropriate intervention. Surgical procedures may include hip reconstruction or osteotomy to preserve hip function and prevent painful arthritis. Physical therapy complements surgical treatment. Regular orthopedic follow-up throughout childhood monitors for scoliosis, limb length discrepancy, and other skeletal complications. Case 25. Parents of a newborn diagnosed with Seckel Syndrome ask about life expectancy. The infant has congenital heart disease requiring surgical repair. What information should be provided? Option A. Life expectancy is always less than 10 years. Option B. Survival depends on severity of complications. Option C. All patients die in early childhood. Option D. Life expectancy is normal.